Apologies for the background noise. And this is a series of World Patient Safety Day. We're celebrating the World Patient Safety Day on 17th of September. And this will be the 5th World Patient Safety Day celebration to be commemorated across the globe. So we are having a series of webinars starting from this one for today, 6th, and next week on 13th. And the theme for this year is engaging patients for patient safety, which is in line with Global Action Plan for Patient Safety, a 10-year plan for implementing patient safety across the world and across healthcare. And this is a strategic objective number 4, which says we need to engage and empower patients and families to help and support the journey to safer healthcare. So in line with this objective and with the World Patient Safety Day, we will be having 2 facilities presenting today, or 2 organizations. We have Mombasa County, Dr. Neema Ali from Mombasa County. Dr. Neema Ali is the head of Quality and Health Standards, the Department of Health at Mombasa County, and she'll be taking us through quality health systems at Mombasa County and what we could adopt from there. And then we have the team from Moi Teaching Referral Hospital, which will be taking us through patient and family involvement in hospital quality and safety agenda. Mr. James Lebo and Abigail Ansari, who is in charge of clinical audit. For your questions, please put them in the Q&A or in the chat. We'll be able to respond to them. And for any other questions, please feel free to raise your hand and alert us of any challenges that you're encountering. Peter, would you like to invite Dr. Neema to start us off?
Thank you so much, Dr. Rhoda Kalundu. So again, my name is Peter Mtanda. I'll be supporting Dr. Rhoda in this moderation of the sessions, as we have a very good panel of speakers today, and we'll want to start with Dr. Neema Ali Mohammed. So Dr. Neema, if you can just be putting up your slides as we introduce you. So Dr. Neema Ali is the head of the Quality and Health Standards Department at Mombasa County. She's been part of setting up the county healthcare quality systems. She has been very instrumental in terms of engaging, the entire arm of the patient safety, patient engagement, the clinical care component, the healthcare workforce, building the capacity of the county departments, and linking the county to the national streams of support. And he'll be talking to us about quality health systems in view of sort of macro level system support, looking at the county of Mombasa as an example. Over to you, Dr. Neema, as you proceed with the presentation.
Thank you, Dr. Ari. I'm humbled and I'm happy to be here today. So I will just introduce myself again. I've been introduced twice. My name is Dr. Neema Ali. I work for the Department of Health in Mombasa County, and I head the unit of Quality and Health Standards. I'm a doctor, a medical doctor by profession, and I have a master's in public health, health system strengthening. So allow me to put the video off. I look forward to an interactive session. I shall be asking the listeners to jot in their thoughts and their comments as we unfold. So.
Sorry, Dr. just a quick interruption. If you want to restart the presentation so that it does not show the slide notes.
Can you see?
We can see the slides, but it's on slide notes. It shows the presentation.
Sorry, let me just try and exit again.
Okay, sure. Thanks.
Just a minute. Okay. Any movement?
Not yet, but maybe
Not
loading.
yet.
Just give it a few seconds.
All right.
Perfect. You can now proceed.
Is that okay?
Perfect. Now you can proceed. Thank you.
Okay.
Sorry
Thank
for that.
you. So today I'd like us to go through quality health systems. Yeah. And I'd like to engage our listeners, and feel free to put your thoughts on the chat. What are where is quality applicable in healthcare? I want to ask that question. Let's ask ourselves, where do we apply quality in healthcare? So just maybe some 30 seconds, and perhaps the moderators can assist in reading out the participants' comments, answers. Can we write our comments on the chat?
Yes, sure. I can see one or two hands raised up, but if we can just put in our comments on the chat, I think that will be okay. Thank you.
I can see laboratory, it is hallmark of healthcare, in services offered. Someone else said everywhere, in surgery, drug prescription, administration. And someone said, I think quality applies in all facets of healthcare. So yes, MCH services. Right. So thank you for your participation. I agree with all of you. But particularly, I would say that we would apply quality management. Sorry, are you able to see my slides?
Yes, where is quality applicable in healthcare? That is where you are.
Okay. Unfortunately, it's not scrolling on my side. Okay. Yeah.
Okay,
so as you can see, quality is applicable in all facets of the health system. That is including leadership, governance, human resource. They are all interconnected for us to be able to achieve quality management. So it is applicable in all areas, not only service delivery. And the reason why I emphasize this is because most of the time we look at the health quality in health at service delivery points, but we need to apply it in all other sections of the health system. So moving on, I'd like to share some experiences working in the unit of quality and health standards over some years. And I'd also like your opinions. What those who've been in healthcare, what has been contributing to the success in quality? Again, you can put your answers on the chat. Before I move to the next slide, I'd like us to just have a very brief interaction and discussion. What contributes to the success in quality in healthcare? What are these driving factors, in your opinion? Let me know. Again. Patient-centeredness, very good. Anybody else? Naila, thank you. I agree. Having that patient-centeredness. Compassion, Naila, thank you again. Anybody else? Okay, so for the purpose of saving time, I shall proceed. And these are just a few of what I put down in my experience, but they are much more than this. And one of the key components of success in quality is having leadership backup or support. That vision that is created by the organization to move towards quality systems, yeah? Having quality management governance structures and coordination structures, this will enable accountability across the various levels of the health system. So knowing who oversees the quality, where, at which level, and what are the roles and responsibilities of these people. Having profound or a certain level of knowledge on the QI processes is also very important, because we want to undertake continuous quality improvement. And remember, this is not only knowledge, the technical knowledge, but also knowledge on the QI process. How am I going to improve from this level to that level? Whether I'm in accounts, whether I'm at a service delivery point at the pharmacy, but I need to have the knowledge on the QI process so that you can be able to take your indicators or your activities from one step to the other. And remember, improvement is incremental, even if it is slow, but any improvement is a success. So another success component is a multidisciplinary approach. And I can't emphasize enough the importance of having a multidisciplinary team. And I'll give an example of some service delivery points. For example, the CCC. CCC requires multidisciplinary members of different departments for it to be able to improve on some parameters. It will need lab, it will need pharmacy, and so on and so forth. Another stronghold that we have benefited from as Mombasa County is the collaborations that we hold between the public and the private facilities. So we work together to improve quality in healthcare, not only in our public facilities, but we work closely with the private facilities so that where we fall short, they're able to come in, whether it is knowledge-wise, and where they fall short, we're able to also step in. So this has particularly worked well in some areas of service delivery, whereby we collaborate to improve on patient outcomes, for example, in referral pathways and many others. So another very important cutting across the entire quality system is having a very elaborate monitoring and evaluation system. So this is where you're monitoring your entire quality management systems, from having the M&E tools, the M&E modalities, knowing how often to collect information, looking at this information and interpreting it so that it can inform you on your decisions or interventions, priority areas. So an elaborate monitoring and evaluation system in quality improvement is very important. Finally, and it's not, and I'm not limited to this list, but one of the success stories comes behind you being able as an organization to recognize your healthcare workers at a regular interval, being able to appreciate them. Various recognition, it can be certifications, it can be ceremonies, it can be having the Employee of the Month boards, but these are very key in terms of encouraging our healthcare workers to continue with the efforts, putting continuous efforts in quality. The next slide would be to look at examples. What are examples of quality improvement interventions or quality improvement projects that you can do within the different building blocks. And I'm not limited to these are just examples. So for example, in leadership governance, the leadership of the facility or the organization can say, we want to improve on our employee satisfaction levels. That is a quality improvement initiative at that level. Under health financing, we can say we want to improve revenue collection for the entire institution, and that is what we are embarking on. Human resource for health can take up a project on, for example, improving timely reporting to work. Yeah, and of course, all these are monitored closely to see incremental or whatever changes that you expect. Under the health information systems, you can have the use of innovative information technologies to improve some service delivery parameters. We have some of our facilities that are using special applications to monitor the non-communicable diseases like hypertension and diabetes, and they're able to get in touch with their clients in that kind of platform. So this has improved access significantly, and we are looking at innovative ways of how to use these information systems, not only at service delivery point, but at different points within the health system. So some of the service delivery quality improvement initiatives could be reducing maternal and perinatal deaths, improving some family planning uptake, cervical cancer treatments. So based on your data, based on where you feel like you have gaps, those are the areas where you can focus on improving. And health products and technology, we can work on things like reducing prescription errors. This is where the pharmacists are very active, recording any prescription errors, liaising with the prescribers, working on ways of making sure that prescriptions come in complete, yeah, and so on. Then under infrastructure, improving access. For example, we can work on improving access to people living with disability, and we have seen this in Mombasa County, whereby we have some of our facilities that are actually having sign language facilities so that they can improve access to those people who require such to access services and are not able to because of a lack of such facilitation. So for Mombasa County, we are guided by the Kenya Quality Model for Health. And under that, it encompasses work environment improvement and problem solving or task achieving. So under work environment improvement, we have the 6 S's. That is sorting, setting, shining, standardizing, sustaining, and the 6th S being safety. That is just in a nutshell. So basically what we do is carry out 6S activities at different work stations. It can be your desk, it can be your cabinet, it can be the pharmacy store, the dispensation area, it can be the accounts office, yeah? So you just want to organize your work environment in such a manner that you will achieve maximum productivity with minimum wastage of time, other resources, movement, yeah, expiries. So apart from work environment improvement, we are guided also by the problem solving or Kaizen. Some of you may know it as continuous quality improvement. Both these are applied together to bridge gaps. Some gaps may be big, some gaps may be small. So for example, if you have a problem in pharmacy where you are having expiries or stockouts or a disorganized pharmacy, and you embark on 5S or 6S activities whereby you declutter, you arrange your things in a systematic order whereby you can easily retrieve and identify where things are, then you will find that you will start having reductions in your expiries because you already know which items came in first, which items are expiring when. So for the Kaizen process, We have a 7-step methodology. This is again defined under the KNH, which we follow as a standard curriculum for Mombasa County. This is where we work to improve problems that would take about a week to some months, some planning, so that we can see a change in our indicators. Yeah. I will share some photos here of some before and after photos of 6S activities. This is work environment improvement. And as you can see, this is just a simple OPD cabinet for dispensation of drugs. And you can see before, it was quite disorganized and it looked like there was no space. But after the 6S activities, the cabinet is now in good order. It is easy to retrieve any items, and we have even created space. Another example is one of our dispensaries. This was a waiting bay, the before photo showing a waiting bay that had so much clutter. Following the 6S activities, you can see there is now proper ventilation, lighting, and there is actually space for the clients to actually sit and wait. And finally, you can see this is another 5S activity of one of our dispensaries. And most of the people don't believe when they see this photo because it is such a major transformation. This took some little time, not little time, but it took some time for them to plan, budget for the shelves, put them in their AIEs, and until they were able to achieve this kind of setup. So they have improved their work environment, and you can see the huge difference. They were even able to create an office space at the center. So next, I would like to share a case study of one of our sub-county quality improvement teams, which took a Kaizen project. That is, they were solving a problem which they noted within their sub-county. And this is Likoni Sub-County Quality Improvement Team. And their project was on reducing maternal deaths. So while they were doing their data review, they noted that there was a high number of maternal deaths in the year 2021-2022 from April to March within that sub-county. So we have 6 sub-counties in Mombasa administratively, and this is one of them. And they looked at their health management team as in terms of quality improvement, looked at this data and decided to embark on reducing these deaths. So following further analysis and investigations, they noted that 5 out of 11 of these deaths were due to poor maternal referral systems. Consequently, after picking your theme, they went into a situational analysis and a root cause analysis. And some of the root causes that were identified included knowledge gaps. Yeah, these were knowledge gaps on referral guidelines, and even the manner in which our health facilities were able to respond to the various emergencies or situations on referral. Then there was the lack of standard operating procedures and standardized referral guidelines on the maternal and neonatal healthcare services within the sub-county. The thirdly was poor linkage between the referring and the receiving facility, and the poor response from the referring and receiving facilities within that sub-county. Remember, this is an administrative unit. It is not a hospital. So there are several hospitals under this administrative unit, both public and private. And just to clarify, this project was able to incorporate both public and private facilities in their improvement project. And you can see this health system approach. So what did they do after noting the root causes? Countermeasures were established in order to address the gaps. The first gap, bridging the knowledge gap. Capacity building for all their health facilities that were offering maternal and neonatal care within the Likoni sub-county. So this included, again, both private and public capacity building. Then there was continuous mentorships that were conducted on obstetric and emergency maternal neonatal care to the facility in charges and also the maternity in charges. The healthcare workers were also capacity built on their response during referral, and also the proper use of the customized referral tools and the referral registers to heighten the awareness of the community on health-seeking behavior. Community dialogues were conducted on the importance of seeking healthcare on time. To bridge the lack of the referral guidelines, they were availed. The referral guidelines were availed, and the SOPs were also developed. So these were just adapted from the 2014 National Referral Guidelines, and they were customized to the Likoni sub-county. They were developed and distributed, the referral SOPs, and the customized referral forms. So now whenever any referral happens within the sub-county, they are all using the same standard documentation and procedures of referral throughout the system. In terms of poor linkage, they were able to improve linkage between the referring and the receiving facilities by having several activities. So here they identified and appointed referral coordinators. So all facilities within that sub-county, public and private, have a referral coordinator whose contacts are well known by their counterparts. They developed and distributed a referral directory. This is whereby all services that are offered within the health facilities in the sub-county were listed. And this directory is very important where you wish to refer a client for higher services and you're not sure which facility is offering which service. So when you refer to this directory, you're able to immediately know this is the facility that offers the service and this is how I can contact them. Another thing that was done was the procurement of extra telephones to improve on communication and response during the emergencies. There was a WhatsApp group that was established for the purpose of coordinating referrals. So this is where all coordination, most of the coordination was done. There's also engagement between the facilities. Do we have blood? Who can you assist me with this? So there's a lot of communication there in this WhatsApp group, and it's specifically for referral purposes. There was a referral consortium that was formed within the sub-county, and this included all stakeholders in referral, not only health stakeholders, but even the non-health stakeholders. Remember, this is where we have even the community, we discuss our referral data. We have even the other departments, like this Department of Inspectorate, because sometimes you require escorts at specific locations and time. So this is a multidisciplinary, multi-sectoral consortium. Then community dialogues on maternal perinatal death surveillance and community verbal autopsies were being conducted very regularly, and every time these community dialogues were happening on other matters of maternal and perinatal deaths were also being discussed. Finally, we cannot sustain gains without strengthening our monitoring and evaluation on referral, and therefore there was established an elaborate M&E system to track all the referral data, and this referral data is the same data that is also discussed in the consortium meetings. During this project, there was weekly tracking of maternal and neonatal indicators. So moving on to what were the achievements? What did we achieve after doing all this? And I will draw your attention to this frequency table. This was a table that was capturing the situation of some referral indicators before and after implementation of the countermeasures. So you can see we had incomplete documentation of referral forms that were 10 before and 2 after. Then lack of the referral coordinators. All the 10 facilities that were assessed during that situational analysis had no referral coordinators, but after, only 1 didn't have a referral coordinator. And let me just bring you to the visual of the same so that you can relate. And you can see the blue bar graph represents the frequency before the continuous quality improvement project. And the orange represents after. These are the variants after the project. And you can see a significant reduction rate in documentation. Documentation improved, coordination structures were better established, and communication, as you can see, communication before referral was being done very well. There were no, there's no yet, or sorry. You can see there is no orange. My God, just a minute. You can see here, it is at 0, and here it is at 0, yeah? So that is a significant improvement. Coming to the maternal death trends, we're still in our results, and you can see we came from maternal death of 11 within the sub-county to a reduction of 3 deaths in total for the following year. And you can see that was between April 2021 to March 2022, and the orange bar represents April 2022, sorry. This is April 2022 to February 2023. Sorry, this is a mistake. So you can see in our hospital deaths were 7 before the project started to improve. And after, we had 1 hospital death for that particular year. And we managed to reduce the community deaths by a half. Still, we have a lot of work to do there, but we could see the ripple effect. So I think with that, I will like to acknowledge the Almighty God for giving me the opportunity to give this presentation, and for all the listeners here today being able to attend. I wish to acknowledge the county government of Mombasa and its leadership, and the Department of Health as well, and the department's leadership, the county and sub-county quality improvement teams, as well as Ganjoni Dispensary Work Improvement Team, Kisauni Dispensary Work Improvement Team, Likoni Sub-County QIT for their marvelous work, and the Society of Quality Healthcare Kenya for allowing me this opportunity. Any questions?
Thank you very much, Dr. Nima, for that wonderful presentation. And thank you for showing us the real journey that one of your facilities has taken to ensure improvement. And we clearly see the components that are required, the necessary ingredients for improvement. Just as we wait for questions, I'm yet to see a question in the Q&A. I'd like to just ask what on the patient side, I mean, quality improvement is about the people, and you've talked about the staff and the changes they put in place. But on the patient side, were they involved in this process? Did you engage them in this process to understand some of the gaps they're experiencing, and any feedback after the changes were put in place from the patients? Are they happier? Do they feel there's more that should be done by Ganjoni team?
Thank you, Rose. I can't say that our project directly interacted with the patient in terms of getting their feedback. We do have a continuous, although we do have a continuous way of monitoring clients' opinions and satisfaction levels. In fact, We've just completed our last satisfaction survey in August, and we are still in the phase of report writing. And part of those patients were the inpatient maternity clients that were captured in our exit surveys. So I don't know if I answered your question, but we did not have a one-on-one with the clients. We focused mostly on strengthening the entire system so that our patients can be safer.
Yes, you've answered the question, and it's good that you're thinking about the patient and that you strengthened your system so that now you could get the feedback from them on the changes that are there. And I'm seeing a question from Ruth Jahonga. What issues did you find at the community? And another one from Elizabeth Opondo about patient experience data. But I think you've answered one for patient experience data, that you're in the process of collecting data after the implementation to see what did the patient feel after this. So the question about community issues at the community level.
So what issues did you find at the community? Yeah, so our issues at the community were basically about the delays in accessing healthcare. So our clients, and you can see we had 4 deaths at the community in the first year before we started our project, and we had 2 deaths the following year after the project had been implemented. The biggest challenge we are having at the community level is the delay in seeking care. The health seeking behavior at the community is, we are still very much, our community relies mostly on, especially the Likoni side, wakungas. I don't know if you have heard of wakungas. They are like birth attendants, traditional birth attendants, whom first the clients prefer to go to, and then when things get bad, they now rush to hospital, but sometimes it's actually quite late. So we are working very closely with the wakungas and telling our clients, you are free to come with your traditional birth attendant, even in the labor room, but come and deliver at the hospital. So those are the kind of engagements we are trying to be flexible and also just talk to the community and empower them on the importance of seeking these services at an early time, and in fact, just the skilled services.
Thank you. And I think you've also answered Ivan's question on contributors in community death. Is it the traditional birth attendants or is it the late referrals? And I like that you've expounded that you're now involving the patients and their families to come with their preferred birth attendee or attendant to seek professional services or to use a facility that can be able to support them. Finally, the last question before we move to James Lebo and Abigail. Maybe James Lebo and Abigail, you could be putting up your slides if you have any. This is from Joanne Olale. She's saying, congrats on the good work. Given the scarcity of resources, how was the team in Ganjoni able to convince the authorities to pay for shelving rather than buy more drugs?
Okay. So the beauty about the Kaizen process is that it adopts a bottom-up approach. This is where the frontline healthcare workers, the ones who are actually wearing the shoes, decide or notice their own gaps. Some gaps are not just data informed, but some gaps, you see such a store looking like that, the people using it feel it. So for them, when they embarked on it as a quality improvement project, they started to included it in their annual work plan, okay? And in your annual work plan, you have a mirror budget to support that work plan. And this is the same budget the facility now submits further for approval. And when they're given the authority to incur expenditure, it is part of the things that have been approved. So they planned for it.
Great, thank you.
I don't know if I answered this question correctly.
Yes, you've answered it. It goes back to the slide you shared about what is necessary for us to have success in quality, leadership, backup, and support,
Mhm.
knowledge on QI process, multidisciplinary approach, public and private collaboration, an elaborate monitoring and evaluation framework, and recognition. So yes, you've answered it about the leadership support and being intentional and planning for the
Yes.
process to happen. Yeah, so, all right, I've seen there are a few more questions. Maybe if you could take some time to type the answer to them, or if you're,
Sure.
yeah, or you could answer them
type.
up. Yes.
Okay.
So thank you very much, Dr. Nema. I hope you are not dropping off, that we'll still have you until the end. In case any other questions come up and we're able to ask you about this. Now we'd like to, thank you. We'd like to hear from Moi Teaching and Referral Hospital on how they engage their patients and their family for safety. So we have Dr. James Lebo, who's the patient safety coordinator, and Abigail Onsare, who's a clinical audit coordinator for Moi Teaching and Referral Hospital. James Lebo, without much ado, allow me to invite you to say hi to us and do a bit more introduction about yourself as you start the presentation. Thank you.
Okay, thank you. Thank you very much, Dr. Kalondu. Sorry for that. Thank you very much, Dr. Kalondu from KNH. This is James Lebo from Moi Teaching and Referral Hospital. We are very much honored today to host this, one of the very important activities in engaging patients for patient safety webinars, which is part of the activities built up towards celebrating the World Patient Safety Day. At the onset, I want to say that we'll do this jointly with Abigail Onsare, who is our clinical audit officer in MTRH, whereas I coordinate patient safety activities in the hospital. I really want to appreciate the audience, the host organization, and we hope that it will be interactive. We will approach this in two parts. We will allow Abigail to do the slide presentation. Then I will come in the discussions about any questions that will come our way. Thank you very much. Welcome to this station. I wish to hand over to Abigail Onsare to proceed with the presentation. Thank you.
Thank you very much. Could you please put your slides on slideshow?
Thank you so much,
comes up.
Tim, for this forum. We are basically going to present our story of patient safety in MTRH, but with a specific emphasis on this year's patient safety theme of patient involvement in safety. So without much ado, you allow us to start. So just give us a minute to set it up on slideshow. Are you able to see the first slide? We moved to the first slide. I don't know if it's reflecting from your end.
From my end, no. Peter, can you say it from your end?
No, it isn't on slide show yet. Maybe try again.
Yes, we've seen the first slide, but it's not on slideshow.
Dr. Kalondo, I don't know if you're able to hear us. I don't know if you can see the first slide of the presentation.
Yes, now I can see the first slide. Kindly put it on slideshow. Thank you. Abigail, we can't hear you.
Just give us a minute. We are sharing the slides again. We're not able to move the slides. Just a minute, kindly.
Okay, so as we give Abigail and James a minute, Dr. Neema, maybe you could take one more question if you're still around with us.
I'm still around. I was
Yes, and
navigating
there's
the Q&A part.
yes, and there's a question
Yeah.
about the Wakungas being involvement of the Wakungas in the verbal autopsy.
Yeah.
Regarding the community deaths. Maybe you could expound a bit more on that. And also, are there incentives for the traditional birth attendants when they come to the facility with the clients?
Okay, so this is dependent on the facility's agreement and engagement with the traditional birth attendants. There are some facilities that who have taken up improving skilled birth delivery as a project to improve the births at the facility level. And some of those facilities have offered what are the incentives for their TBAs or the TBAs that bring the most referrals to the facilities. You know, things like kangas, monthly like recognitions, like they sit and have lunch and say, this month, this one did so many referrals. Here is a leso, or you know, we have these traditional wares there. So some facilities do offer such kind of incentives. It just depends on how well they have engaged their community. What else was there? Community, are you able to conduct verbal autopsy? Yes, our verbal autopsies, yes, they involve the Wakungas, the neighbors, anybody who would have information as to how the death happened at the community level. So yeah, they're usually quite comprehensive, and sometimes these deaths are a bit tricky to handle because the nearest relatives tend to maybe even run away to.
Sorry, you're not able
relocate.
to share our slides, so we've sent it to Dr. Kalondo so that she shares it for us kindly.
All right, thank you, no problem. Let me just
Dr.
check.
Kalondu, are you able to see our slides?
On the
Hello.
screen, on the screen right now, no, but let me check email and see.
Hello, Dr. Kalondu, are you able to see our slides?
Peter, maybe you could, as I check for the slides, please.
Yes. Are you able to see now our slides?
No, we can't see your slides from this side.
You can see it. Huh?
Yeah.
Okay, let me start sharing again. There.
So as we wait for that, thank you, Dr. Neema, for that, and thank you for the innovative ways in which you're engaging the traditional birth attendants, and by extension, the patients and their families. So thank you for that simple, innovative, yet very important ways of engaging the caregivers who the patients trust at that moment until we change their trust to the healthcare system. James, yes, we could see your slides. They're still not on slideshow, but let's start. We will figure it out as we continue.
If you click from the beginning, it is possible on that slideshow, go to that first icon from beginning.
Yes.
It's okay. I think we can just continue.
Sorry about that challenge. So you just allow us to continue the presentation.
Yes, please. There's a bit of an echo on your end, but yes, please continue with the presentation, Abigail. Thank you.
Okay, so it's now okay. We can continue. So this is just a brief introduction about MTRH. MTRH was started in the year 1917 with a bed capacity of 60 to cater for the health needs of the people who are existing in this environment. And then it served as a district hospital before attaining the referral status in 1998. The current bed capacity is 1,100 for now. It's a multi-speciality hospital that serves the internal East Africa region, including the larger North Rift and other 22 counties. It's located along the road in Eldoret Town, Uasin Gishu County, which is 310 kilometers northwest of Nairobi. So, Moi Teaching and Referral Hospital has been covering patient safety and marking patient safety day from the year 2019. And we know internationally patient safety as an annual international event was established at the 72nd World Health Assembly in 2019. So since 2019, MTRH has been commemorating this very important day. And I will just share with you, that was 2019 under the theme
Abigail, we can't hear you. James, could you please take over? Abigail seems to have dropped off or have connection issues. We can't hear. Peter, can you hear?
Yeah, I can't hear both, but
Okay.
I think Abigail was insinuating that she shared the slides with you. Do you have them? Maybe.
The voice is what we need. Let me look for the slides, but we need the voice.
Yeah.
Yeah, as
Quite tricky.
yeah.
Maybe anyone from MTRH, you can raise your hand. Or text in the Q&A.
Are you able to hear us?
Yeah, you are back on. You are back on, Abigail.
Are you able to hear us?
Yes, we can now hear you well. But are you able to present?
Sorry,
Are you
I
able to
think
share your slides?
yeah, we are sharing to your email so that you share for us kindly, because we're having a challenge sharing.
Okay, sorry everyone, just give us 30 seconds. We see if we can present it from through Dr. Kalondu.
Abigail, you could continue just talking as the slides get here. They're not yet here. James, kindly fast track the slide.
So Abigail or James, are you able to speak to the story on the slides while Dr. Kalondu gets it up for you guys?
Yes, I can continue presenting as we are sending the slides to Kalondo.
Please proceed.
Okay, thank you. So as I was just saying, MTRH has been taking part in marking the Patient Safety Day ever since its inception in the 2019, when in the 72nd World Health Assembly, when patient safety was declared an annual international event. So I will just give the background of the birth of patient safety in MTRH. This was started in the year 2012 with a baseline survey that was done by the GIZ team. The survey was on practice and knowledge of WHO 9 intervention measures on patient and staff safety. The results of this baseline survey recommended that there is a need for patient safety enhancement in Moi Teaching and Referral Hospital. This gave birth to the idea of establishing a patient safety unit within the hospital. So in the year 2016, in collaboration with Linköping University, Sweden, MTRH established an exchange program that now was the beginning of the patient safety journey in MTRH. In October 2016, the same year, MTRH staff were trained on patient safety. In 2017, there was an appointment of multidisciplinary team to spearhead patient safety activities within the hospital. Then officially in 2019, a hospital patient safety policy guideline was developed and initiation of patient safety unit done. And then in that same year, that is when the world declared that there has to be a patient annual safety marking day. And we are proud to say that patient safety had already been established even as the world was marking its first safety patient day. And we took part in that patient safety day as was declared by the National World Assembly. So far in MTRH, we have made tremendous gains, tremendous achievements. And in the year 2020, the Ministry of Health recognized MTRH as a key stakeholder. And with that, they nominated one of the patient safety coordinators in the National Patient Safety Advisory Committee. In the year 2022, the members that were nominated to the National Council actively participated in developing the first National Patient and Health Workers and Quality of Care Policy, which is already disseminated. Then in the year 2023, which is now current, we have participated as a hospital in development of training modules on National Patient Health Workers and Quality of Care Policy. Other achievements that we have as a hospital is we now have a fully functional patient safety unit that is in charge of handling all patient safety issues, including incidents management, incidents analysis, incidents communication, root cause analysis. We also have an occupational health and safety secretariat that is certified which has a certification of OHS 45001 as an institution. That is something we take pride in. Then we also have an institutional public complaints committee and a customer relations office that is fully functional to address all the patient issues. So in line with this year's theme of engaging patients for patient safety, we actually acknowledge as a hospital that the patient and the family are core and are the key pillars. So we actually regard them as partners in their care. So they form a key part in the healthcare team, and we incorporate their opinions in provision of healthcare. So we have been able to see the benefits of engaging patients in their care. I can highlight a few of the benefits that have been highlighted. that we have seen over the years, that engaging the patient in their care, it provides access to the patient's history, it improves safety and awareness, it brings important perspectives about care, including cultural and religious preferences of the patient. It provides timely feedbacks. It helps build trusting relationships with healthcare providers. We also engage the family. It's not just the patient that is engaged in care. And the benefits of engaging the family has been that you can see that it offers familiarity with patient medical history and normal behavior of the patient. It helps in recognition of early warning signs. It gives an opportunity to teach family members about care that is being given to their patient. It helps provide timely feedback and builds trusting relationship with healthcare providers. There's a model that we use as MTRH for engaging patients. I'm very optimistic that we'll be able to share the screen so that all of us can be able to visualize the model, but I will still go ahead and talk about the model. The model can only be overemphasized, even by Dr. Nema's presentation, that for any activity that is in the hospital to be successful, the leaders have to be at the forefront in advocating for this. So in MTRH, leadership involvement is key, and we have seen the support in ensuring that patient safety activities are implemented through the able leadership, all through from the CEO to the managers. Everyone is involved and interested in ensuring that patient safety activities are a success within the hospital. So through that, the leaders are great advocates of ensuring that the family and the patient are engaged in their care. And in line with engagement to the family and the patient, we are also driven by our core values. Our core values of openness and trustworthy. In our core values, we actually advocate that we need to be open and transparent and honest in handling the issues that occur within the hospital. So we have various activities that form the pillar of this model. And the first one is patient and family conferences. This is a multidisciplinary team involvement whereby the multidisciplinary team approaches the patient during care in the ward round. So we have the doctors, the nurses, and the various healthcare teams, including the pastoral team. We also include them and the patient and relatives. Here we are able to discuss the modalities of care and also seek their opinion in giving the care to the patient. Then we also have root cause analysis. Through the root cause analysis, we engage the patients and families in the root cause analysis. Through them, we are able to get very insightful information with regards to the expectation. So in case of an incident, we involve the families and the patients in discussing the incidences that actually occur in the hospital. So we call in the family and inform them openly about the incidences that have occurred, and we have an open discussion and way forward to those discussions. Then another model that is a pillar in engaging patients, we have the hospital patient surveys that are done annually. And here we are able to get the customer's opinion on how they rate the care that they received and what are the expectations. What areas can we improve as a hospital as from the patient's eyes? Then we also have another pillar, which is the customer relations. We have a very strong customer relations department that are in charge of getting all the customers' complaints, feedbacks, compliments, and are able to highlight them. I can see my slides are up. Thank you very much. I had continued, I was in the patient engagement model. So I can briefly go through as we had talked. I was saying in line with the theme for this year, our focus is on the patient and the family. We had already discussed family engagement and the benefits of patient participation in the care. So we can move to the next slide, please. Next slide, please. Oh, this is the model we are discussing. So this model has, I'm on the model, please. So on the model, we have the 4 pillars that I've already talked about. I was talking about the customer relations. If you can please go back to the model kindly.
Is this it? Abigail?
Yes,
Oh,
thank you.
Okay, sorry.
Yeah, so I was discussing on the customer relations as a core pillar. We have a fully functional customer relations department that helps engage on the patient and the family directly. Here, the patients and the relatives have a platform to discuss their issues openly. And then as a hospital, we actually have the patient service charters, which are displayed everywhere within the patient care centers, the wards, the entrance, everywhere. We have the patient service charter that tells the patient, what are your rights as a patient? What are your responsibilities as a patient? And that is a route of engagement for us, for the patient. Then I had already discussed openness in incident communication, and this is guided by our core values of honesty and openness. Then we have a strong leadership support that helps all this be able to function. Then what enables us as a hospital, we have the safety culture. The safety culture allows us to know that anyone can make a mistake. And in that, we are alert and aloof and looking out that we don't make that mistake. But in case a mistake happens, it is a no blame culture in MTRH. Our emphasis is to learn from the mistakes that happen to prevent the next mistake from happening. So kindly let's move to the next slide. So the next slide is just showing how our leaders, this is our CEO, Mr. Wilson Arosa, who's actually engaging one of the patients. It shows that as an institution, leaders are leading from the front in patient engagement. So this is one of the management rounds that always happens every Monday. Every Monday, the entire management team goes round to involve the patients and get their feedback. How are our services? What can we improve? That is, what feedback do you want to give us? And this is a weekly activity that has tremendously helped us improve as an institution. It is led by the CEO every week, and all managers within the hospital are involved. Next slide, please. This is just an elaboration of what we had discussed, that in the patient engagement in the multidisciplinary rounds, we actually have a forum where the multidisciplinary team talks to the patient. Then the customer relations also have a role to play. You can see on the first picture, this is the patient charter that I had talked about. Hereby it just shows what are the roles of the patient, and then what is their responsibility even as a patient in ensuring that we give them safe and appropriate care. Then, as I had already mentioned, we have a customer relations team with open channel of communication 24 hours. What I have put there is all the emergency lines that are displayed in all our areas of entrance. These are the numbers that you can quickly reach anyone, from the CEO to the night soup, to the office line, to the hotline. So in case a patient is stuck or a relative, they can openly communicate to anyone they want to reach. Yes, kindly let's move to the next slide. root cause analysis, I cannot overemphasize on that. In root cause analysis, this is where we are able to do the desktop review and guess what are the gaps as from the desktop review. Once we get the gaps, we do a deeper analysis. What are the root causes? What caused this? And then through root cause analysis, we're able to get recommendations for improvement. These ones are done almost after every incident is reported. And then the benefits of actually doing the root cause analysis is that it helps give the patient or the clients an understanding of what actually happened. Why did these incidents occur? It helps them even heal faster. It reduces the blame culture in the staff because you're looking at what are the systemic issues that caused the occurrence of this incident. It also minimizes family frustration and anger. And furthermore, it demonstrates the organization's commitment to learning from the errors that happen. It increases the comfort of the patient in knowing that some good will possibly come out of the incident that happened. Let's move to the next slide, please. So as I had earlier on mentioned, this incident communication to the family. In case an adverse event happens, we as a hospital, we do not hide. However bad it is, we openly discuss to the client. And this, as I had mentioned earlier, is in line with our values of transparency and honesty. And this just helps us know that as an organization, we are ready to learn from our mistakes. We are committed to learning from errors, and it actually facilitates the healing process to families. This has risks involved. The risks that are involved in discussing incidences with the family, as we have seen, is that it can bring out agitation to clients and family. And the members of the family and the patients, sometimes they lack the trust in the health system. They treat you with a lot of suspicion. Yeah, but at the end of the day, you weigh what the risks versus the benefits, and the benefits definitely outweigh the risks. So as a hospital, we actually really do open discussion of incidences. Next slide, please. Then we have a very elaborate feedback system. And the feedback system is what enables us to know where are we doing well, where do we need to improve. And this one, as I said, we have annual surveys that are done, and the annual surveys are targeting both the patients and the staff. And the results that we get from the patients and staff improve what should be done next. It gives us advice, it gives us ideas, and helps rate us. Our performance as a hospital, we are able to confidently say we are doing well or we are doing badly through the feedback that we receive from the customers. Then, what is the way forward? What are we targeting at? Where do we want to be as MTRH? We've already done so much. We are not stopping. So our next aim is to ensure that these patients and families are represented fully through policy formulation and in governance structures that co-design safety strategies. Because they're the consumers of this care that we're giving, they need to be active participants in the care that we're giving them. And that is in line with our theme this year of involving patients for their safety. We can only be able to improve if we are hearing the patient's voice of the story. What is their feel? Other than looking at it from the caregiving side, it is also important for them to give us their perspective. They're the only ones who know what exactly they expect and are best suited to give us a way forward in improving their safety. Then the last slide, we're just asking, are we too busy to improve? Are we busy doing errors? No, thank you. There's always room for improving. Every day we wake up with an intention to do good, and we should not tire despite the challenges that we get every day. For as long as you have a goal, we keep sticking to what we want and not look at the challenges that are ahead. Thank you very much.
Thank
And
you
we are
very
really sorry for the inconveniences that was caused by the heat.
Okay, thank you very much, Abigail, for that wonderful presentation. Once again, we apologize for the slight hitches that we had and the technical challenges that we had, but we're happy that you're able to see what Moi Teaching and Referral Hospital is doing. I'm seeing a question, Abigail, and I think I'd like you to take on this, and this is about do you have dedicated patient advocate department that is outside of management? We've seen wonderful photos, and you've talked about the management doing the walkabout every Monday, leadership walkabout every Monday, but are there patient advocate groups or a department that listens to these patients' concerns? And the still part of that comment from Joanne, she says, well, I appreciate the access to the CEO et al. How will they solve issues affecting all patients and caregivers admitted to your hospital? Abigail?
Thank you for those questions. I will invite Mr. Lebo to help us answer those questions. Thank you.
So thank you very much. Thank you very much, Rhoda. Thank you very much, Abigail, for that. Yes, I have got the two questions from Rhoda, if I got it clearly. Whether we have a dedicated patients champion or patients department. Yes, I want to confirm to every listener here that here in MTRH, with the acknowledgement of the importance of the patient's contribution towards improvement of healthcare safety, hospital management through our CEO recognize that we have and we must appoint a patient advocate. So as we speak now, we have two patient safety advocates who are actually all around the clock, responding to all patients' concerns. Even when there is a patient voicing a concern, even from the clinics, from the units, these messages, as Abigail has said it, we have an open conduct to the CEO, open conduct to our corporate communication, and these complaints or concern will be channeled immediately to the patient advocate on the ground. This patient advocate will link up with the patient or the caretaker on that, for that matter, and they will be able to pick out their concern immediately. So it's a full-time job. We have a senior manager who has a clinical knowledge, and they go by the customer relations coordination nurse. They always interact with the patients. Each complaint per day, she gets quite a number of complaints, and that is well taken care of. As of the question, accessing the CEO of Moi Teaching and Referral Hospital, I think this is one thing as a patient safety coordinator in MTRH, I am really proud of, because this has gone a long way to get the trust from the patient. Any patient can text the CEO, any patient could call the CEO and they will receive their numbers. And any concern from the patient is never left unattended. And the feedback is given back to the patient through either the patient safety advocate or from the patient safety unit. Thank you very much.
Okay, thank you very much, James, for that response. And still, to add on to that question.
Back to you. I don't know if we've answered that fully or there are any gray areas for clarification.
There's still more clarification needed, and somebody is asking what makes up, Benta is asking what makes up Patient and Family Advisory Committee, and do you have any volunteers who are non-hospital staff? So do you have any patient advocates who are non-hospital staff? How does the patient safety composition look like? Who are the patient safety advocates? There's a question about, based on the feedback survey, what are the top 5 common complaints that you receive from patients and families? And another question on guidelines used by the senior leadership during the walkabout rounds to better analyze patients' concerns. So maybe we could start with that last one. Do you have any guidelines that the senior leadership use to understand and listen to the patient better?
Yes, Dr. Yes, Dr. Kalondu. Picking from the question you just asked, whether we have guidelines for engagement of patients by the senior leadership. I would start by saying, actually, it is a very deliberate action by top management to the extent they have actually scheduled that patient affairs, staff affairs will be scheduled on Monday. So it is there even in our performance contracting approaches in the hospital. So it is well laid out, and basically it's about reaching out to the units, reaching out to the patients, and getting to understand from the ground what are the patients feeling on the ground, what are the care given, are the services as per the standard set. Apart from engaging the staff, hospital management engages the patients. They would want to listen to the patient to know whether they got the service, whether there was delays in surgery, whether there was delays in offering a certain service. So it's very structured, and there is a well-documented minute by minute issues that emanate from these management rounds in the hospital. So management has clear guideline, I think, supported by our internal homegrown institutional patient safety guidelines, where we really encourage that management checks on the patient care that happens in our unit. So we have hospital institutional patient safety guidelines policy, which was approved 2019. I think we are very grateful that the national aspect now, as the national was developed, the national policy guidelines for patient and staff safety was developed. And I think it is a great opportunity for MTRH now to link up with the national ministry, so we can harmonize the two guidelines. But in principle,
Yes.
the guidelines are very key and elaborates the patient engagement from the institutional guidelines. Thank you.
Thank you. And just still on that question, what are the top 5 complaints that you normally receive?
Yes, Rhoda. The other question?
Yes, top 5 common complaints that you receive from patients and families, either during the walkabout or through the feedback surveys that you do.
Rhoda, this is labor again. I get the concern on the topmost complaints that we have recorded from the customer advocate. Yes, the first and foremost is mainly the nature of the complaints, actually majorly on communication breakdown between the patient and the caregivers. And this translates to major errors. If the complaints are never, these communication breakdowns are never attended to in time. Mainly, it will be reflected in the many errors that we record in the hospital as medication errors or errors that goes to the patient. So the first one would be breakdown in communication. Number 2 is delayed service delivery, delays in service. Every time patients complain of delayed services, the patient advocate in MTRH reaches out to the patients. And when they reach out to the patients, many times it is the understanding, the communication between the caregivers and the patient misunderstanding, because, for example, a test is supposed to be to run for 2 hours. So the clinicians will collect the samples, and then the patient is not explained to that it will take you 1 or 2 hours to get this result so that we can proceed with the plan of care. Many times you will see the patient complaining and they will say, I have been delayed in service. But learning from the patient safety advocate on the ground, these have gone well with our patients because they are able to reach out to the patient, explain to them, this service requires some time so that the analysis is being done and the result is released. Some other dissatisfaction from the patient would have been a delay in radiology imaging and reporting. So the patients expect that when they do an imaging from the radiology side, they expect to get that film, go back to the doctor. But when they get the film, they are told, allow us 30 minutes to do a report on the film. Many patients will complain that we have been delayed for some reason, and basically it's a communication. When we analyze the root causes, would be a communication breakdown between the patient and the caregiver. The other common complaint would be it includes even rudeness of the staff, language of the staff. Sometimes we get complaints like this, that a staff for some reason is probably using harsh language to the patient. But when we analyze this further from the patient safety advocate, they're able to mitigate these issues and get a clear understanding of what the management of the patient is being done. The other complaint which has come outright from the patient would be like, the patient will complain and say, we have been admitted in the hospital for probably 3 days, but nobody has attended to us. Now, when we look to these complaints, many times it is boiling down to communication. The patient has not been explained to the care what the plan of care, who is involved. We are expecting some tests, we are expecting a consultant, and next cross discipline consultations. So the patient may not have understood, and they will always complain that nothing has happened. However much, when the doctor sits with the patient and explain step by step the management of the patient within the units, always the patient will understand and they will appreciate. Of course,
Okay.
there are complaints that when you look at it generally, some patients also can complain without assessing the whole care that has been given. And many times we sit down and explain to these patients that there is so much care that has been given, which will not warrant actually that the patient has not been attended to. So many times when we analyze it and we explain to the patient, they will always get satisfied. Thank you.
All right. Thank you very much, James, for that elaborate explanation about the kind of complaints that you do get. And I do agree with you. A big percent of complaints, patient complaints, are from communication. And I think even when we look at the Q&A part, we're seeing quite a bit due to communication, CPD points.
Rhoda, are you there? Yes, I get you.
Yes, CPD points is a key concern on the chat box and the Q&A section. So maybe we'll give a minute to the KNH research team to address the issue of CPD, or maybe reach out to the team, to the individual members who are asking about CPD points, then we should be able to do that. So
Rhoda,
final
please speak up a bit, Rhoda.
Oh, sorry, you can't hear me?
Yeah, please raise it up again.
Okay, sorry. Final question to James and Abigail is about whistleblower staff who courageously come out and report other staff or an incident that occurred that caused harm to the patient. How do you deal with that, and how do you establish an environment of trust and a culture of safety amongst the staff? James and Abigail.
Thank you very much, Rhoda and Peter again. As regards to whistleblower protection, Actually, in MTRH, I would say there is also a guideline with MTRH where, as regards to protection of the whistleblower, and this is very much known to the staff. The policy guideline on the protection of whistleblower has been shared across board to the staff, that where they report an incident, they will always be protected. The other aspect of promoting a reporting culture, non-fear culture, is that the CEO, Dr. Wilson Arwasa himself, goes out to the staff and tells the staff that where you report incidences, it is an unblamed, non-punitive process where a staff documents using the structured reporting tools in MTRH. The staff actually will not be punished, and then a team will be constituted to analyze the incident involving the staff. They involve staff. Actually, they listen to the staff. They check with the records and the standards whether the error was actually intentional or non-intentional. And the staff are very much open and honest to report exactly that what has happened. The other aspect where I think this openness has been promoted is about engaging the patient in the analysis process. Many times when you engage the patients and we bring the patient and the involved staff at a later stage together, we have seen a mutual understanding between the patients when the doctor explains to the patient the exact cause of the error and the processes that were done. All the root cause analysis we have seen, the patients and the relatives are able to appreciate and get to know the real problem which was there, and that it was never intentional. This has come out very well to allow our staff report. No staff I would report today to this end has been punished based on a root cause analysis report or recommendation that was done from the patient safety unit. No staff, by all means. And when we do these recommendations, normally it goes to the top management, the CEO, who will action various heads of departments, directors, and action people to try and implement the recommendations done. The approach would be, when you make recommendation, we don't look at the individual, we look at the system. To the extent, Rhoda and Peter, we are now proposing in MTRH that probably the analogy of RCA, root cause analysis, which is a scientific way of analyzing incidences, has been as assumed a punitive thing. We are now thinking of rethinking. Can we use something what we call comprehensive systems analysis, so that when you get a team to go, for example, to pediatrics or emergency department to analyze an incident, they go in the name of, we are coming to analyze the system, a comprehensive system analysis. Many times when we talk of root cause analysis, people will say, fine, they will do they will drill down to me. So, but when we think of giving it a new approach like comprehensive systems assessment, we believe going forward that we can achieve more in terms of improving and learning from errors.
Yes.
I think I have handled that.
Yes, thank you very much, James Lebo. And just to answer a question from Benta about accreditation process towards patient safety locally. Yes, Benta, we do have, and they are part of our partners for this webinar, Safe Care, Healthcare Standards. They do accreditation, and they focus quite a bit on patient safety and quality of care. So compared to other accrediting bodies locally, Safe Care pays special attention to that, and maybe we should organize for a webinar on that where we get to hear more about the services they provide. I've also seen a question on whether KNH or MTRH have a dedicated marketing and patient safety units to respond to queries regarding staff professionally. Yes, in KNH, yes, we do have patient safety unit, patient affairs unit, hospital ethics committee, marketing and communication unit. And you can use these platforms to raise any concerns. I work in the patient safety unit, and therefore feel free to reach out to us. If you use the KNH research email, it will get to us. Alternatively, you could find ways of reaching out to you if you share your contacts with us. Thank you very much. Finally, let me, as we come to the end of this, Dr. Okto, is there something you'd like to add? And Peter, before I give a vote of thanks to the teams and the participants.
Thank
Not
you.
me, Dr. Rhoda, maybe Dr. Lydia. Thank you.
No, thank you. I think we are truly glad for MTRH and the Mombasa County team. Asante sana. Thank you.
Okay, thank you very much. I'd like to give thanks to Mombasa County Department of Health Services, the Division of Quality and Health Standards, the MTRH team led by James Lebo and Abigail Onsari, KNH Research and Training Division, which has provided us with this platform. And I'd also like to give special thanks to the following organizations that are supporting World Patient Safety Day. Ministry of Health, this is leading the activity, World Health Organization, Kenyan office, Society for Quality Healthcare Kenya, Aga Khan Health Services East Africa, Home Access, Safe Care Healthcare Standards, Infospective, and Kenya Association of Pharmaceutical Industry. They're all part of the players that are supporting these educative sessions, and we look forward to having you in the next one. The next one is next week on 13th, and we will still be focusing on Patient Safety Day. So karibuni sana. About the CPD points, yes, we've marked that. I will forward all these concerns to the relevant team, the KNH CPD team, and I'm sure they will reach out to you. The ones for KMPD, for the doctors, I'm sure yours are having a different approach from the ones who need their CPD points right then issued in terms of token or in terms of a number. So we will reach out to you, and just be patient with us. I'm sure very soon you'll see them uploaded. Remember to log in with your names and to register for every session so that your number, it automatically goes into your number. Thank you very much. We'd like to thank you all for participating in this and for giving us time and for being patient with us, even when we had a bit of challenges, technological challenges. Asanteni sana. Do have a good day, rest of the afternoon, and see you next week. Bye.
Thank you. Bye.